afternoon. It's great to see so many people interested in weaning and possibly diaphragm ultrasound as well. These are my disclosures. So I think if you've been here unless you just walked in, I think I don't need to convince you that the diaphragm is important. And it probably plays an important role in a whole range of issues related to mechanically ventilated patients, including ventilator-induced lung injury, particularly in the context of spontaneous breathing, weaning, synchrony, and even possibly the risk of being readmitted to the ICU. But we're really focused on the issue of the role of diaphragm in weaning. As you know, the diaphragm is a dome-shaped muscle. Much of its surface is opposed to the inside of the chest wall, and it's composed of two portions, the crura, which attach directly into the lumbar spine, and the costal region, which attach to the lower margin of the rib cage. So you can use diaphragm ultrasound to image the costal diaphragm in the region of the zone of apposition, where the diaphragm is situated between the rib cage and the liver. And in that location, you can see this pointer is not working very well, but you can see the pleural membrane, and below that the peritoneal membrane, and the relatively hypoechoic layer situated between those structures is the diaphragm. And so this is actually quite easy to do. You simply use the same ultrasound probe that you use to place a line. The linear array transducer is certainly ideal to have as high frequency as possible because the diaphragm is relatively close to the surface, so a higher frequency will give you much better resolution of the pleural and peritoneal lines, and therefore the muscle itself. Now, during the diaphragm's contraction, it shortens, and almost all of that shortening occurs in the zone of apposition. This was nicely demonstrated some time ago on MRI, where you can see that during inspiration, the shape of the dome doesn't really change very much, but the diaphragm shortens substantially in the zone of apposition located between these 2 points here. This laser pointer is giving out on me, I think. But the point is that the shortening occurs in the zone of apposition, and accordingly, as the muscle shortens, it has to thicken because of the overlapping of actin and myosin fibers, and you can image that thickening or that contraction on ultrasound. And it's been nicely demonstrated repeatedly that as the inspiratory volume increases, the thickness of the muscle increases, as shown here on the right. So what does this actually look like on ultrasound? This B mode image or video clip is shown on the left here. And you see that as the subject inspires, the muscle thickens up. And we'll just look at it one more time. You can see the thickening there during inspiration. And if you put the ultrasound machine into M mode while maintaining that same location, it will monitor the change in thickness over time over that one particular point where we set the M mode line. And that allows you to compute the expiratory thickness of the muscle, the inspiratory thickness of the muscle, and we quantify the percentage increase in muscle thickness as the thickening fraction. And it can tell you typical range of values of thickening fraction in healthy subjects at rest, such as yourselves, breathing quietly, is probably in the range of 20 to 30%. During a maximal inspiratory effort to total lung capacity, you'd expect to see anywhere between 50 to 100% thickening, and the absolute lowest value you would see in a person with intact diaphragm function during a maximal inhalation would be 20%. So that's a widely accepted cutoff for diagnosing diaphragm dysfunction. So this allows you to monitor a number of things. First of all, you can see the variation in thickness during inspiration, and this allows you a very feasible, non-invasive means of monitoring inspiratory effort, particularly in mechanically ventilated patients where it's challenging to sort out whether the patient's tidal volume is generated by their muscles or by the ventilator or some combination of the two. This allows you to directly image whether or not the patient's breathing and how much. So we're talking about weaning in particular, and the question is, how can diaphragm ultrasound help weaning? And I think there's three specific ways in which it can potentially facilitate weaning. First of all, an increasing number of studies are showing that it is a useful tool to predict extubation success. So in the same way that you use the rapid shallow breathing index, you can use the thickening fraction of the diaphragm during the SBT to make some prediction about whether the patient's going to be successfully weaned. Secondly, it's useful to diagnose the cause of difficult weaning. And then thirdly, and somewhat more speculatively, it's potentially useful to detect and prevent diaphragm injury during ventilation. So I'm just going to run through these three issues very quickly. So, as I said, several studies have looked at the utility of measuring diaphragm thickening fraction during the spontaneous breathing trial, and they all consistently show fairly impressive results. This was the first paper published by Ernest Danino and Dennis McCool out of Rhode Island, and they measured the tidal thickening fraction during a spontaneous breathing trial using pressure support of 7 with PEEP of 0. And they developed this receiver operating curve with the sensitivity on the y-axis and then 1 minus the specificity on the x-axis. And the area under this curve gives you a quantification of the overall predictive utility or discriminative utility of the test. And what they found was that the optimal cutoff of thickening fraction seemed to be around 30%. And this cutoff had a sensitivity for weaning success of 88% and a specificity for weaning success of 71%. You can see the distribution of thickening fraction values for patients who failed extubation and who succeeded on the right. And what you can see is that patients who failed extubation had much lower thickening fraction values. So this suggests that this non-invasive tool for assessing the diaphragm's ability to contract gives you some useful information about the patient's chances of doing well after you remove the endotracheal tube. And this was confirmed by a second study published by an Italian group, and they measured thickening fraction during a maximal inspiratory effort, so from residual volume all the way up to total lung capacity. So a somewhat different maneuver that was used to measure thickening fraction. They showed even better predictive utility with an area under the curve of 0.95. They identified an optimal threshold of around 36%. So if you were above that threshold, you were much more likely to succeed weaning with a sensitivity of 82% and specificity of 88%. And then this very interesting data, soon to be submitted by Martin Andres, who's had a number of papers cited already today in this session, looked at thickening fraction measurement during a spontaneous breathing trial, again with pressure support of 7, PEEP of 0, and compared it to a number of other potential predictors of weaning success. So they measured twitch tracheal pressure with magnetic phrenic nerve stimulation. They measured diaphragm excursion, and they measured the rapid shallow breathing index. And what they found was that the thickening fraction of the diaphragm was as good as the twitch tracheal pressure at predicting whether or not patients would succeed in life post-extubation. And again, the area under the curve was close to 0.9 with sensitivity of 77% and a specificity of 94%. And they again found an optimal threshold of around 30%. So we have pretty consistent data that this is a potentially useful tool to predict extubation outcome. Now the question remains as to whether this is so informative that it significantly improves your prediction over just using something like the RSBI. And that question needs to be explored in some detail in the future. All right, so secondly, diaphragm ultrasound can assist clinicians caring for difficult to wean patients because it can help you to make a diagnosis as to why the patient cannot pass their spontaneous breathing trial. As you know, weaning failure is basically an imbalance between supply and demand, the capacity of the respiratory system to tolerate a load and the load that you're placing on that system. And essentially the capacity of the respiratory system is a function of the patient's diaphragm function. So it's important to know whether or not the patient has any capacity to use their diaphragm to tolerate the load that you apply once you put them on the SBT. So, as I said earlier, diaphragm ultrasound is actually a very useful tool to do this, and this was first described by Dennis McCool's group just about 20 years ago. They took patients with idiopathic hemidiaphragm paralysis and measured maximal thickening of the diaphragm on the paralyzed side and maximal thickening on the functional side. And what you can see is that on the functional side, the thickening fraction was always above 20%, whereas on the paralyzed side, it was always below 20%. And this cutoff for thickening fraction of 20% as a diagnostic criterion for severe diaphragm dysfunction has been validated in a number of additional studies. And for example, the Italian group I mentioned earlier showed that the maximal thickening fraction was correlated with maximal inspiratory pressure in mechanically ventilated patients. So this is a useful, valid tool for diagnosing diaphragm dysfunction in mechanically ventilated patients. Now the problem is, of course, what do you do with that information? This is, I talk about diagnosing diaphragm dysfunction in my ICU and elsewhere, and people always sort of say, okay, well now we know the patient's diaphragm is dysfunctional, what do we do now? And we've already had some helpful discussions about how to optimize respiratory muscle function, but one particular intervention of some interest is inspiratory muscle training. This is an example of what that training looks like here. You use this valve that applies a threshold load, meaning that the patient has to inspire to that threshold pressure in order to generate any inspiratory flow. And you set that, well, there's a number of different protocols, but you set that valve basically so the patient has to generate anywhere between 30 to 50% of their maximal inspiratory pressure. And you do several repetitions, a couple of sets a day for a specified duration of time. It's just like weightlifting for your diaphragm. And interestingly, we're just in the middle of, we just completed a systematic review of the literature, and it's pretty consistent and convincing that these techniques can improve inspiratory muscle function. Interestingly, there was also improvement in expiratory muscle function. But some exciting data about what we might be able to do once we diagnose diaphragm dysfunction in terms of fixing the problem and helping the patient get off the ventilator. Now, finally, there's a question of whether we can use ultrasound to detect and prevent diaphragm injury in ventilated patients. This figure here, which has been shown a few times already, depicts the trajectory of diaphragm thickness in patients in different subgroups of mechanically ventilated patients. About 40% of patients in this prospective cohort study had no change in diaphragm thickness over time. Another 40% had significant decrease in diaphragm thickness during the early course of ventilation, and then a small subset had a surprising early increase in muscle thickness during ventilation. And so these data sort of, particularly the decrease in thickness, entirely consistent with what we already know about ventilator-induced diaphragm dysfunction. But what's interesting is that as we study these patient outcomes, it seems pretty clear that these changes in muscle thickness are substantially associated with poor clinical outcomes, and that both decreases and increases in thickness are associated with prolonged duration of ventilation and a high risk of complications of acute respiratory failure, so tracheostomy, prolonged ventilation, and in particular a significant increase in the risk of reintubation. So there clearly seems to be real issues going on with the muscle that we're seeing with the ultrasound. Now what's quite tempting to think is that possibly we could adopt a new, what we call muscle protective approach to mechanical ventilation, where we set the ventilator to maintain optimal levels of inspiratory effort, and we might be able to use ultrasound to help determine what the optimal level of ventilator support is. So in this figure here, you can see that we have diaphragm thickness on the as a percentage of baseline on the z-axis. We've got the duration of ventilation in days on the x-axis, and then on the y-axis projecting into the plot is the diaphragm's contractile activity. And we found that when the diaphragm was inactive, the diaphragm thickness tended to decrease over time. When it was active, well above normal levels seen in healthy subjects at rest, we saw a significant increase in thickness over time. And what just is so intriguing is that when patients' inspiratory effort levels were similar to those seen in healthy subjects at rest, sort of the blue shaded region, there was relatively little change in thickness over time. So what this kind of suggests is that if we were to titrate ventilator support to maintain relatively normal levels of inspiratory effort, we may be able to avoid this diaphragm injury and accelerate liberation from mechanical ventilation. But of course, a lot more work needs to be done to substantiate that hypothesis. So to sum up, I think diaphragm ultrasound is extremely helpful in managing the difficult to wean patient. It helps you to predict extubation success. It's a useful tool for diagnosing the cause of difficult weaning, specifically diaphragm dysfunction. And thirdly, I think the data emerging suggests that it's a useful tool to detect and potentially prevent the diaphragm injury that occurs as a consequence of ventilatory support. So just if you're interested in these issues and you feel like coming to Toronto, we are running a mechanical ventilation course next month, and I can assure you that there won't be any snow in Toronto on April 26th. So you'll be most welcome to come out, and there will be several training sessions on diaphragm ultrasound at that course. Thanks very much.
Thank you. We have time for one, two questions.